maybe we can move on to the next case, another very interesting case by Dr. T.P. Vignesh, a colleague of mine from Arvind, Mumbai.
Yeah, I'm just sharing the slides, just a minute. Yeah, I thank Dr. Anand and Sauls for giving me this opportunity. My case is a case of bullous variant of CSCR, where I used eplerenone along with micropulse cellular laser subthreshold treatment and successfully managing it. 40-year-old male patient presented with defective vision in left eye of 10 days duration, history of similar complaints in the past, and history of previous laser treatment, left eye 4 years back and right eye 2 years back. No other positive history, and he was a mechanic by occupation. His BCVA in right eye was 6.9 and left eye was 6.24, anterior segment within normal limits. Right eye revealed an old subretinal fibrotic strand as well as few old laser spots and RPE changes. Left eye had a severe subretinal fibrin, dense subretinal fibrin, along with ILM folds and as well as subretinal fibrin along the superior and inferior arcade as well. This picture shows the inferior bullous retinal detachment. And OCT of the right eye revealed a few RP changes as well as a PD and subretinal fibrotic strand. And the left eye revealed serous macular detachment with dense subretinal fibrin. And the below one, like just below the fovea, revealed multiple PEDs and the dense subretinal fibrin. The B scan revealed the inferior bullous retinal detachment. So I proceeded with combined angiography, and we saw like multiple leaks. You can see like along the arcades as well as just near the fibrin. So dense leaks were seen. So the treatment options that came to my mind were thermal laser, micropulse laser, PDT, and eplerenone. So the problem with laser was that since the fibrin was so dense, it may be difficult to focus and give the laser exact to the leaking areas. And so I decided not to go with the laser, and PDT is not available. The only option I had was eplerenone. So I did a baseline serum potassium. It was within normal limits. No other systemic abnormality was detected by physician. So I started the patient on tablet eplerenone 25 mg once daily and followed up after 15 days. So here we can see a very good drastic reduction in subretinal fibrin as well as inferior bullous RD coming down. And we can see this decrease in the fibrin as well in the fundus photo as well. So now I started increased the dose of eplerenone to 50 mg, and the serum potassium was still within normal limits, and patient didn't have any adverse effect. So at the end of 1 month, there was further decrease in fibrin as well as the inferior bullous RD. At the second month, I could see like still there was decrease in the subretinal fibrin as well as the inferior bullous, but at the fovea, the fluid was persisting. So I repeated the angiography and then found that leaks to be reduced. Leaks have come down in most of the areas. So now I thought, since the fluid at the fovea is not being, why not to add micropulse laser? So now then I added micropulse laser after reduction in fibrin to the remaining leaks. The power I used was 300 milliwatts, duration 200 milliseconds, 5% tube cycle. Spot size was 100 and number of spots 140. So after 3 months, we can see very good reduction in SRF as well, and complete resolution of the inferior bullous RD. And we could see the remaining subretinal fibrous strand. At 4 months, there was like complete resolution of the foveal SRF as well. So from baseline to the 4 months follow-up, there was complete resolution of the condition. We can see here the progress from baseline up to the 4 month and the OCT, and the bullous RD resolved completely within 3 months. So we all know bullous variant is a rare manifestation of chronic CSC, and this was first case of bullous CSCR wherein combination of eplerenone and micropulse laser was used and a complete resolution was achieved. Eplerenone and subthreshold micropulse cellular laser produced a complete resolution of bullous CSCR in 4 months. The improvement of vision from 624 at baseline to 612 at the final follow-up in my case. A combination of eplerenone along with micropulse laser can be considered as a therapeutic option in bullous variant of CSCR. These are my references. Thank you.
Very nice, Vignesh sir. As always, your cases are very interesting. So considering the challenge of non-availability of PDT in many places, MicroPulse definitely is setting up its role in CSR, and we all have experienced that subthreshold laser works really well in CSR. But one thing which I think it was brought in the very early of this webinar was the application of subthreshold laser in presence of fibrin. Does it change your settings? I would not think so. I would just be using the same settings, because as we understand that you do not get significant inflammation in the areas where the subthreshold laser has been applied. So you really do not expect a significant reaction or scarring just because of the laser. Any other comments on Vignesh's case?
Yeah, I just want to comment on I don't know how, I mean, like there is control trials suggesting that epiferin doesn't really make much difference. But I think that the always the difficulty is, you know, in the control trial, you got a multiple number of patients coming in. And so whether that might be a specific case that, you know, when you got a more severe one, like the one that you have, less likely to spontaneously recover, whether that might be a role, you know, or we're using epiferin. So I think it's something that we probably won't be able to see. And concerning about control trial for CSC, I think it's very difficult that PT, I mean, like the PACE study, you probably notice on all the list that Oxford is one of the sites, but then I was not involved directly. And because the study was partly funded by Novartis by providing the drug, and also and also using 810 laser. So I think that we wasn't really doing the study right in a way. But again, to try to repeat the study is almost impossible because Novartis would not fund it again. You know, and again, for people that who, you know, to buy the PDT, you know, to do a study again will be very difficult. So I think it's a realistic view of doing that. And even doing a study in DME, that the diamond study, I was one of the grant applicants. It took us like 4 or 5 years to get the grant, you know, and then another 4 or 5 years to do the study. So we started that project almost 10 years ago. So it's very difficult to get people excited about, you know, getting you know, grants to do it. And again, that was why that some of the reality, the real world data or a retrospective study are needed. You know, so but whether that as a society we were hoping that we can actually do some pragmatic study. I think a proper randomized control trial might not be necessarily fully possible. But again, we welcome all colleagues, different idea, sharing information, sharing idea, and doing something that more pragmatic, you know, as even the US, the DLCR-NET study are quite often very pragmatic. So they do have funding. So it's kind of like, you know, I think we need to be realistic about it. We are still trying to persuade the DLCR-NET to do some of the micropulse study. I think the Diamond study is certainly that one piece of evidence that the DLCR-NET was keen to look at in more detail. So the Diamond study is very specific. They are looking at central involved DME, but they are very the edema was not very severe. So I think is a more similar to the protocol V, I think, but decided different parameters and so on. And comparing conventional laser with to subthreshold laser. So there's still a lot of things that we don't know about. You know, certainly that like even today, different experts are still using slightly different parameters and so on. So I think that is still something that I hope the guideline that we provide as a you know, as a kind of like background, and then we explain the logic that why we're using those guidelines, and just hopefully that the guideline be adapted as time goes along, and then we were able to do some more pragmatic study.
Perfect. So I think, I mean, we've had a wonderful session. A couple of questions have just popped up. This one from Dr. Barbara. Thank you for keying in. To Dr. Vignesh, how do you know if it was eplerenone or the micropulse which is working? I think you mentioned that you started with eplerenone because it was so bullous, then got the fluid down, and then you went in for micropulse. Am I right? So I think that kind of answers the question that the whole idea was to get the velocity down and then go in with the micropulse. And then there's a question from Dr. Janani. about has anybody used micropulse for juxtafoveal hemangiomas. So yeah, so has anybody tried that for juxtafoveal vascular tumors or DPT? So I'm not so sure. Yeah.
I mean, these are my initial thoughts. Interesting question, but I would think that, we need to really understand what is the pathogenesis of the fluid in a particular disease. If we really think about choroidal hemangioma, it is primarily because of the larger abnormal choroidal vessels, which is actually exuding the fluid. I really doubt that the micropulse would be able to really work on these abnormal choroidal mass, because micropulse, we are like trying to work primarily in the area of RPE or choriocapillaries, may not be very effective. I'm not sure if anybody else has any experience.
TTT can be tried. TTT.
Yeah, TTT can be tried. Yeah.
TTT we have tried and we've had good results. So the issue with the micropulse is this pathology is quite deep. Micropulse works in the RPE choriocapillaries area, so it might take care of the fluid. From an exudation point of view, they won't address the primary pathology.
Yeah, there's one interesting question there, I think, from my colleague, Dr. Vyas. I think, why not try micropulse PDA for patients with pre-existing traction? I think that makes a lot of sense. I mean, possibly. I mean, where we do not want to give aggressive laser, which can increase the traction, probably, I don't know.
I agree with Jyoti that, many a times when we are doing PRP for these PDR cases, I'm more interested in looking at the posterior hyaloid, because if posterior hyaloid is really thickened and elevated, you would really not dare to do PRP, rather take the patient to the OR. So those are the cases probably we can consider this. Thanks, Jyoti, for a fantastic question.
Those would be the expanded indications.
No, but
Dr. Ajay, you have
Dr. Giridhar, on one side we are doubting the use of micropulse laser for PDR. On the other side, we are saying that we use it in DRD, which I think is a little extrapolating.
No, I don't think we are talking about TRD. We are talking about patients with nearly normal vision, where there is a pre-existing traction, and a PRP may precipitate a tractional detachment. So there are many. We're looking at patients with very good visual acuity with PDR, where there is a pre-existing traction, where when you do a PRP, you can worsen. So probably in these sort of cases, we give very little of laser. So in such a situation, whether there is a role for this sort of this thing, that's what we are looking at.
Yeah, I think something to think about, but I think certainly my experience with micropulse PDR in general, not particularly the case that you're mentioning, is not effective. I think we said, at least I believe that for PDR you do need to kill some retina. I think the whole concept of micropulse, you don't kill retina. But again, just like most things that you can't be generalized in. That's why we talk about patient to patient. I think in very specific case, there might be reason for doing certain things. But certainly we have tried it when Jeff was publishing data on PDR patient or early PDR patient. And we actually even did up to 10,000 burns, because of the more spot that you need to cover the same number of spot, and it's still not very effective. But again, we did a small number of cases, never publish it, because again, this is really a publication bias that if you don't think it will, you tend not to publish it, either. So I think it's still way to be seen. I think that my experience might be negative, and then we stop doing it. And also when anti-VEGF come in, we tend to do combination therapy. But whether there's a role for combination therapy, whether there's a role for just treating the ischemic area with micropulse, and again, that need to be still way to be seen. Nowadays, but again, it is slightly more difficult. I would say it's slightly more difficult than doing this kind of study in Europe and US, because I think that anti-VEGF are commonly used now in PDR patient, but might be something that can be done in Asia.
I just want to make a quick comment about Vignesh's case of bullous CSCR, because these were the cases which I would see very often in India, not that often here in Pittsburgh. But I think eplerenone, actually, I started using eplerenone in bullous CSCR very often, because when you have an exudative detachment, you have no other choice other than, you are not able to do PDT, or you have to take the patient for external drainage, which you would still be reluctant. If the eplerenone works, that's great. And in my experience as well, eplerenone did work. There was a question from audience that was it an eplerenone effect only, or delayed eplerenone effect, or the micropulse made a difference? To answer that question, I would think that once your eplerenone has worked and resolved the leakage, you should always be considering some form of additional treatment such as PDT or micropulse. And I'm sure Vignesh did not have the access to PDT, so he went ahead and did the micropulse, which probably is going to hold on the recurrence in these cases. So I think combination is certainly a great choice. Congratulations, Vignesh.
Thank you.
So on that note, I think we've had a scintillating session. I'd like to thank all the speakers for excellent talks. I'd like to thank our chairpersons, Dr. Victor John, Dr. Girdhar, and all our panelists, Dr. Lita Gu, Dr. Ken Pong, Raja, for joining in. Thank you so much. It's thrown up a lot of thought. It's thrown up a lot of new questions. But I think the effort is on to put out those guidelines, and I'm sure we will take it from here forwards and try to establish some sort of evidence, level 1, hopefully, and make this something of a means of giving us another form of finite therapy. So I'd like to thank everybody else who's joined in. Thank you all for attending. Thank you very much. It's been a great
Thank you so
session.
much.
Thank you. Thank you very much.
Thank you.
Thank you. Thank you.